So very good morning to you all, respected chairperson, co-chairman, and my respected judges. Uh, Thank you for this time. The title of our study is Retinal 106 Episcleral Plaque Brachytherapy in Recalcitrant retinoblastoma. Sorry, my slide is not going through.
Dr. Lomi, may I request you to please be a little louder because we are not able to hear you.
Yeah. So I have no financial interest to disclose. There is a paradigm shift of management of retinoblastoma from mutilating enucleation to more globe and vision salvage. A few decades back, chemotherapy has been the main treatment option available for managing retinoblastoma. However, with the increased use of chemotherapy, now frequently we see recalcitrant case to chemotherapy. So the treatment option for recalcitrant retinoblastoma is depend upon the tumor size, location, laterality, related tumor seedings, and status of the opposite eye. There are various treatment options which is available now, which is used in adjuvant with chemotherapy, like thermotherapy or cryotherapy for smaller thickness tumors, and a targeted chemotherapy like intraarterial chemotherapy, intravitreal, or periocular chemotherapy. So with the invention of brachytherapy and its popularized ocular uses for past few decades has been a great boost for managing retinoblastoma recalcitrant to chemotherapy. So the goal of the treatment is to deliver curative dose to the tumor while offering the least possible radiation to the normal ocular structures. So the aim and objective of our study is to find the early outcomes of Rutinum 106 episcleral plaque brachytherapy for recalcitrant retinoblastoma. The outcome measures are eye salvage rate, the tumor control rate, and the complications. It's a prospective interventional case series conducted at Dr. Rajendra Prasad Center for Ophthalmic Science, AIMS, New Delhi, and the study period from June 2017 to September 2019. AIMS ethical clearance and then patient and legal guardian informed consent were taken. And recalcitrant retinoblastoma, in our case, is defined as tumor recurrence after chemoreduction or failure to regress after 6 or more cycles of systemic chemotherapy with or without focal consolidative therapy. Inclusion criteria are Group B, Group C, and D retinoblastoma, tumor recurrence or failure to regress after 6 or more cycles of systemic chemotherapy with or without focal consolidative therapy. And a unifocal active tumor with apical thickness less than 6 mm and largest basal diameter less than 60 mm. Active vitreous cysts and the subretinal cysts were excluded from study. And the ruthenium plaque from the BB company from German was used in all the cases. An appropriate guideline set by AARB and with overviewed by the institutional radiation safety officer were followed. International intraocular retinoblastoma classification were used for grouping the retinoblastoma. The dose distribution is calculated with Excel sheet manual calculation by medical physicists, and the requested information like clinical diagnosis, tumor dimension, location of tumor, measurement of tumor distance from optic nerve and fovea were given for calculating the durations. The models and shapes of the plaques were decided based on the largest basal diameter and the location of tumor. The standard surgical procedure were carried out by a single surgeon in all the cases. Coming to result, 10 eyes of 10 recalcitrant retinoblastoma were recruited in the study. All 10 patients have bilateral retinoblastoma where other contralateral eyes has been enucleated due to advanced retinoblastoma not responding to chemotherapy. So in our group, we have got 60% are group B, 30% are group C, and 10% are group D retinoblastoma. Coming to age, their mean age is 4 years, and then 5 were male and 5 female. 6 patients have right eye and 6 have in the left eye. And mean follow-up months is 22 months, and radiation dose at apex means is 3977.77, and the scleral dose in gray is 146.38. So here's a case scenario. This case with recalcitrant group C retinoblastoma, and this is post brachytherapy at 5 months. Another case with recalcitrant group C retinoblastoma where other eye has been included because of extraocular RB, and this is the post brachytherapy after 16 months. Another child with group C recurrence is there. This is the 6 month brachytherapy. However, at 8 months, you see the tumor recurrence is there, and 11 months the tumor have increases, and then patient have to undergo enucleation in this case. In another case with group B retinoblastoma, this is at 2 month post brachytherapy showing the tumor regression pattern. And this another child with group B retinoblastoma with twice laser photocoagulation. This is post brachytherapy pictures. This group D retinoblastoma post chemo reduction However, there was recurrence and the tumors were with the 8th cycle of systemic chemotherapy, the tumor regression is seen. So this is the post-radiotherapy 12 months. So coming to results, the visual and IOP were insignificant in first baseline and the last follow-up, and the apical thickness and larger basal diameter were significant in the last follow-up. So tumor control rate and the eye salvage rate are 80% at mean 12 months, with tumor radiation related complication in our group are seen radiation retinopathy at 11 months and then hemorrhage at 7 months. So review literature see our case are comparable in tumor rate and then in the eye salvage rate. And in complication also, we have got this 10% RD, 20% proliferated retinopathy, 10% vitreous hemorrhage, and 20% radiation retinopathy. So in conclusion, Ruthenium-106 episcleral plaque brachytherapy has been found to be an effective and safe focal therapy in selected retinoblastoma cases recalcitrant to chemotherapy without active vitreous and subretinal seedings. Thank you.
Good work.
Dr. Lomi, I'm Dr. Sonali, one of the panelists. I have one couple of questions for you.
Yes.
Plaque brachytherapy is effective when the tumor is localized.
Yes.
Okay, but in one of the cases which you have shown in your presentation, like the tumor was multifocal, it was all over the fundus, but still you advised plaque brachytherapy in that case. So what was the reason behind that? In one of the cases you have shown the
there's one case with group B retinoblastoma which I've shown.
But the tumor were multifocal, so
there was multiple vitreous seedings were there, which are regressed multiple seedings were there, regressed vitreous seedings.
But in the like you have told ki like all patients with active vitreous and subretinal seeds you have excluded.
They were excluded. But here in this case, it was regressed vitreous seedings were there, post intravitreal chemotherapy.
So regressed, then it should have come in your presentation. Ki regressed tumors we have included in our study group because.
Vitreous seedings. Those were excluded. Active vitreous seedings and then subretinal active vitreous seedings were excluded.
Okay. And what was the size of your plaque?
Size of the plaque, ma'am, we have a 19.8. That's round plaque, and a notch plaque is 11.6 millimeter.
Okay, like in few cases, like the tumor was located in the posterior pole.
Yeah.
So and
ma'am.
So if like one of the side effect is a sort of radiation.
Yes, definitely.
The type of radiation only. So do we recommend plaque brachytherapy in posterior polar cases?
Particularly in that case, we have to do the plaque brachytherapy because patient has already received chemotherapy recalcitrant to it, and also there's lesser this photocoagulation has already been done from outside. So the role of intraarterial chemotherapy here is minimal since the vessels are all sclerosed. So the only option to salvage the globe is plaque brachytherapy here.
So what is the take home? Do you recommend plaque brachytherapy for posterior pole tumors also?
Ma'am, if patient is recalcitrant to at all, like intraarterial chemotherapy also, then we can do it as side of globe salvage. Otherwise, here in all my case.
No, suppose if we have a two option, IAC and the plaque brachytherapy.
Then definitely we should consider for IAC first.
Okay, thank you.
Yes.
What is the average follow-up in your cases?
Sir, average follow-up is 1 year.
Isn't it too short a period to come to any conclusion?
Yes, sir. There's too short because we have started very early in 2017 only. But now, since I've already submitted the abstract now, we have done around 18 cases and the follow-up is around 36 months. So still now they are doing fine.
So it is a little early to present this paper.
Yeah, that was during that 2020 last year. This abstract is fine.
Good work otherwise. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, Dr. Omi. Dr. Mule. Please.
Yes, sir.
Please, go ahead.